You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 20, 2012, and I'm your host, Dr. Jay Portnoy. This is a special workshop held in the section of Allergy, Asthma, and Immunology to train allergy fellows in the proper performance of allergy skin tests. By completing this workshop, the allergy fellows have demonstrated that they are competent and proficient at performing skin tests for allergy practice.
Okay, good morning. This morning we're going to be doing a procedural competency. This is required of all the fellows in their training. The one that we're doing today is immediate hypersensitive skin testing. The forms that we have, and I've kind of gone through this with you already, but the forms that we have are the new forms that the procedural competency work group that I was a chair of basically developed for some of the procedures. I think there's like 8 procedures now that we have forms for. I believe the RRC is going to have about 7. I think it's 6 or 7 that are going to be required with the new with their new recommendations that come out. I think it's in 2013 that they start. But for the main ones, we have these competency forms. There's going to be a series of questions, and you see in the form in front of you. They cover knowledge-based performance and interpretation of the test and an overall competency of the procedure. The reason of doing this is to try to have this based on your competency, not just numbers. Previously, all this had been based on numbers. Did you have 300 skin tests, and if you did, then you were better than someone who had 100 skin tests, which doesn't really make any sense. Especially for procedures that we don't have that many chances to have. Again, you don't have to have 100 to be competent. Some people can have 100 and still not be competent. So the form we have, when we were going to do this, Dr. Miller and myself will circulate through the rooms. If you're waiting for your skin test results to be done, we'll pull you aside and quiz you on the questions on this list. To be competent, you have to answer all the questions right. You have to do the skin tests appropriately. The skin test that we're doing is basically we're going to be doing skin tests with histamine and saline. You'll do alternating histamine and salines, a variety of those on your back, and then after we're done, we'll measure all those. We're going to transfer them to mark them out with pen and then transfer them to tape and then onto a piece of paper like we do with our research studies, and then you'll have the fellows measure out the wheels and the flares and figure out do the math for the coefficient of variance. Basically, it's thought that you're having good technique if your coefficient of variance is less than 30%. So we're hoping that you all were in that 30% range. So we're going to have you get into gowns for those that aren't in gowns already. There'll be two in a room, and you'll basically test each other, and then, as I said, Dr. Mill and I will float around and kind of see how you're doing, and then pull you aside to ask the questions. After we wait for the skin test to kind of brew on your skin, we'll have you measure them, transfer them, and then do the math. And then I'll talk to you later this afternoon about how you did and where we stand with that. Theoretically, to be competent, you have to be able to answer the questions and also get within that 30% range. And if you don't meet all those criteria, then we can't check off your competency for skin tests. If you do, then this competency is finished for you. You don't have to worry about that. And this will go in your educational folder with all your other papers to verify your procedural competencies. Any questions? Okay. So let the games begin.
In order to do the skin testing, we have the skin test tray right there. We have the dermapicks, and we also have syringes. Are we going to be doing intradermal testing also, or just the prick?
We're doing. They're going to just do a couple intradermals just for the practice.
Oh, okay. All right.
On the other. But I'm sure there is an optimal distance. Is that one of our questions, Dr. Miller?
Could be.
It's not listed as a direct question, but it's a good one to think about.
It's one to maybe consider, because there is a carryover of the test results. So if they're too close together, then a negative could become a positive by just sort of empathy, I suppose.
Right. Okay, then I'm going to just write an H or an S.
So what you could do to have them be further apart is to do one on the left side, and then the next one do it on the right side of the line, and that way they're further apart.
There and there. I actually...
No, actually go
here.
like there,
Oh, I see.
there. That way they're not next to each other, they're further apart. Because otherwise they look pretty close together.
I know, I was hoping the salines wouldn't. I see. Right, so I'm going to do all the histamines on the left and the salines on the right. So actually, I think I'll do all the histamines first. Like up on the upper arm. Yeah. It's the most common.
So some of these are already starting to react.
Okay, now we have the
Our first question here is to understand the indications for performing the test and alternatives to skin testing. Did you get that first one?
Yeah, so indications for performing the test. First of all, if you have concerns about environmental allergies, you can test for inhalant allergies. Food allergy is also an indication for skin testing, for prick testing. And then also concern for venom hypersensitivity would be another indication. And then you said the second one was?
And alternatives to skin
Alternatives.
testing.
So there's obviously, you could do blood work to look for IgE levels for these things.
Okay, is one better than the other?
Actually, I believe that skin testing is more sensitive. So that if you have a negative, it'd be more likely that you could rule it out rather than the blood test. Actually, it has a lot more false negative.
Okay.
Or false positive results.
And let's just pick on foods here. If food test is negative, that's always reassuring. If it's positive, what does it mean?
So if it's positive, it means that you could have a food allergy or you may not. But if it is negative, then you're more likely to rule it out.
Okay.
So it's increased sensitivity.
And of course, all these are IgE-mediated reactions, so you got to take the history to figure out is IgE testing appropriate or not. So, okay, very good. So, all right. Supposed to understand the factors that can affect testing. Here, what type of things may make your testing not as good as maybe you want?
So the person that's actually applying the test, so they need to be competent. And then also the actual reagent that you use. As you see, we use just the individual pricks today, but they do have ones that come in panels where you roll, or even the technique, what you do with you twist, or if you prick, that's going to change. Skin color can also make a difference. If you have a darker skin color, it's sometimes hard to see that erythema or the flare. Other things would be your actual reagents, so making sure that they're stored appropriately, or in terms of venom testing, if you mix them, you need to have them applied within that day. You can't have those reagents sitting around. Did I miss any?
How about age?
Age. So the very young and the very old will have decreased reactivity of their skin. So kind of less than 2, you need to be concerned. If you have a negative, it may not necessarily mean that it's a negative test. And the very old also can have a decreased response.
Anything else you think that may affect whether skin test reactions?
Medications.
Yeah.
So antihistamines, it depends on the antihistamine, but more long-acting antihistamines you need to be off for, we usually just tell people a week, but Benadryl can sometimes be just a couple days. Then other things that have antihistamine effects would be your atypical antipsychotics, tricyclic antidepressants, and I, to be honest, oftentimes I'll look through their medications and actually look on up-to-date, or look at micromedics or something to make sure there is an antihistamine effect. Corticosteroids don't have an effect on skin testing. And then I don't believe beta blockers have an effect on skin testing, but there is a question of being possibility of having a systemic reaction if you're on beta blockers. Some people say to stay off them for a couple weeks, and other people say to go ahead and test through them.
Your issue is if you had a systemic reaction,
right.
You need to reverse them. How effective will be your beta agonist?
But it wouldn't just necessarily change the results of your test.
Correct. Okay. And then other antihistamine medications like the
H2 blockers,
right.
yeah. Ranitidine.
Right. Which, how effective, I'm not sure on that one, but it's theory at least. Okay. Very good. So the histamine and the saline are called what?
So your histamine's your positive control and your saline's your negative control.
Okay. What are those for?
That is important in determining the response of your test. So when you're using your negative control, a positive test is actually going to be a 3 millimeter difference in the wheel from the negative control, or a 5 millimeter difference in the flare from your negative control. And your positive, I think, when they used to use numbers, they'd say your positive histamine would kind of be around a 3+, or it's a fairly significant reaction. But we don't really use those numbers anymore. We really go off of measurements.
Okay. Yeah, because everybody has a different scale or may interpret it a little different. So be as objective as you can, I think, is the way to go. All right. When should the test be read?
A test should be read in 15 to 20 minutes after it's applied, so that gives it time to react appropriately.
Okay, very good. I don't know what our timer is, but let's keep...
Actually, histamine's a little bit shorter.
Yeah.
It's more like 10 minutes.
Yeah, and you can see right away some people start to respond here too. Okay. What's the difference between a skin prick test and a puncture? A skin prick or puncture test versus an intradermal test.
Okay. So, the skin prick test is just an epicutaneous test, where the intradermal is actually going to go underneath the skin. In terms of when you do those testing, the intradermals are done for venom testing and for drug testing after you've done skin prick testing. You would not do intradermal testing for foods because you can get a very high false positive rate, and you have a risk for having more severe reactions, especially if the child had anaphylaxis. And then inhalants, most people would say that they're not necessarily standardized. Intradermal testings are not standardized for inhalant panel, but I know there are allergists who do those as well.
Yeah. And what's different about the extract when you go from the skin prick to an intradermal?
So the intradermal is a more diluted. It is diluted.
Right. You'll find a lot of allergists, more so in private practice, will still do intradermals here. It's a debate on utility of that, but of those who do it, they're very selective. They're going for high yield. If someone swears that their cat is causing this problem here, but remember their friend's cat doesn't, that's the usual story. They may go from the negative skin prick to a intradermal to see if they can stir it up a little more.
So correlating it with history.
Yeah. Okay. All right. As far as doing skin tests, what are the potential risk of doing any type of skin test, whether it be prick test or intradermal?
So, obviously you can have itching, which isn't a big risk, but it can be uncomfortable for the patient. And then there is always a risk of a systemic reaction. If you have, especially a very highly allergic patient, or there's always errors in mixing when you're talking about venom and other things, that you can have a systemic reaction where you could actually even have a drop in blood pressure and have very severe side effects. You have to be prepared for that as well, even though it's very uncommon with skin testing.
Right.
If a patient's highly allergic, though, it puts them at higher risk, or if they are on a beta blocker, like we talked about, if they would have a reaction, it may be harder to control.
Right. Okay.
And then a patient with uncontrolled asthma potentially should not be skin tested as well, just because they could potentially be at a higher risk.
Okay. All right. And what type of intervention would you use if they were having a systemic reaction?
So systemic reaction, as we know for allergy, it's epi. So you need to have epinephrine available, and then you can also do Benadryl, H2 blocker, considerable steroid, but epinephrine is going to be your mainstay.
Okay. All right. And then you have the ability IV
sure.
fluid resuscitation here, refractory glucagon.
Lay flat, put their feet up. Yeah, glucagon, if they have beta blockers.
Yeah, positioning, things like that. So, okay, very good. And then don't forget about the respiratory tract you might use.
Albuterol for wheezing, yeah.
So, okay. All right. Tell me what dermatographism is and where it complicates our skin testing.
Yeah, so dermatographism is a patient where just scratching the skin will actually create a wheal and flare reaction. So when you do your skin prick testing, even your saline will cause a reaction. So what you'll see is that everything will be positive, including your negative control, and that's a very important reason to have your negative control as well. So if a patient is dermatographic or does have dermatographism, you should not. That'd be a contraindication to doing skin testing.
All right. This we've kind of already covered here. Peripheral documentation should be measuring the wheal and flare. You already talked about that. And I believe lastly is is talking about the results to the families. Say you got a patient with a cat skin test that's 5/20 wheal and flare here. What's that mean to the patient? Tell them how you interpret that.
So the first thing you'd want to know is what your negative and positive controls were to make sure that. So if your negative was 0, and your positive was, it could be close to, it could be anything, but let's say it was 5/10 or something. Okay. So you can say that it's definitely a positive test because the wheal is over 3 millimeters from the negative control, and the wheal and then the flare is over 5 millimeters. So we do have a positive result. That is a fairly significant reaction. It's equal with our positive control, so that would be a very significant reaction. Then we'd always want to correlate it with the history, so we want to find out if they have any symptoms with cats, as sometimes you can have false positive results. Okay. But I would tell them if their history is there, that they have rhinitis symptoms, conjunctivitis symptoms, with cats, then based on this testing, we would say that they have an allergy to cat.
Okay. All right. So let's say their sibling had one that was, instead of 5/20, it was 10/40. Is that patient sicker?
So it doesn't necessarily correlate with the severity of symptoms, but it does show that their skin is more reactive.
Okay. Very good. That's what I was
But the important thing is to know that it's appropriately bigger than the negative control.
Okay. Yeah, so in summary on that, as a positive test just means, yes, you have preformed antibodies, right, eventually leading to the histamine reaction. None of it predicts severity of disease, and that's important.
Same with the blood test as well.
Right, yeah. We see that all the time with, peanut allergy and things like that. So, all right, that's all I had here, too.
And I was thinking indications as well.
Yeah.
If you're going to do immunotherapy, skin testing is very important.
Yeah.
So those are another indication I missed.
Agreed.
There we go.
All right, how you doing? Oh yeah, you have lots of good histamines.
I get some reaction.
And all of my salines are basically negative. So, the important thing is that you actually feel for the wheal, because sometimes it can maybe look like, you can see here, we don't have any wheals on the salines, which is excellent. But she did have good responses there on the histamines. This one, I know that I dragged the prick when I did that. So, it almost looks like it could have a pseudopod, but actually that was just not appropriately applied. I don't know if this will transfer to tape very well. can also do it on the polar aspect of your arm. Like we said before, the top of the back is better than the lower, and the back is better than the arm.
Proximal.
I've seen a lot of clinics do their skin testing right there on the arms.
I think a lot of it is convenience and
Not having to put on the
right. So, Tara, with the histamine, what's unique about this histamine compared to our prior prick skin test?
Oh, this is going to be a diluted form.
Right, exactly.
We're
And
talking about 1 to 100.
yeah, it actually is labeled for intradermal testing, so that's one thing you want to pay attention to because it is a dilution of the other version here. So here's this one here. Because of our saline sample right now, we just pulled some because we're split in between rooms. This is your saline solution right here. I put an S on it so we know, and I'm going to put it
Right
here.
here. So we'll do a saline and histamine over here.
So I get to be the guinea pig this time.
So we're just going to go bevel up. Just going to feel a poke right under the skin there. Form a small bleb, and then we're
It's kind of like doing a PPD, huh?
And I'm going to put this in. So again, we're just going to go underneath the skin, bevel up. Make a small bleb. And we're done.
Do I have a bleb? Real?
Yeah.
Actually have a little bit irritant effect on your saline too.
I know, that's what I was
Wheel.
saying.
And you've got a good wheel and you got a little bit of a flare around it too. It's not huge, but it's there.
Yep.
It's sensitive.
I'm afraid you're allergic to
I'm
saline.
allergic to saline? Oh, no.
Right? That's true. Look at that.
But that's why you do the negative control. Now, if you did a histamine and it was the size of the saline, you wouldn't say that it's positive.
Right.
Yeah, you definitely have a larger response on histamine.
So you can discriminate.
Right. You gotta look at the difference between the two.
Just go ahead and do
Pretty
this.
good. Okay, so now we're using Excel in order to calculate the mean and the standard deviation. So if you look at this, let me just zoom in. Okay, so the mean is 9.0 and the standard deviation is 1.7, so that gives a coefficient variance of 19%. Wow.
So I passed.
So you passed. Congratulations. Good job. 19%. Pretty good. So is she competent, Dr. Galley?
She's competent.
I
She's
have
met
reached
all the
competency.
criteria.
All right. Very good. Congratulations.
Thank you.
Oop, you're gonna get your form signed off.
On an N1 pass today.
Let me.
You need this sheet.
I gotta sign this.
All right. Good job. Did she get like a little certificate?
The plaque?
No, but if you want to make one up, we can.
Why don't we give them a certificate? You can frame it and put it on the wall in your office. We should
You
do
get
that.
a Dora sticker. It's pediatrics.
All right. Very good.
Oh, look at her.
She looked excited and successful.
Yes.
I think Dr.
Congratulations.
Dowling needed a sticker for the, or Dr. Portnoy needed a sticker. Angry Birds, is that what we decided?
Angry Birds. All right. Well, congratulations. Good job.
Thank you.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.